Hi, good afternoon, everybody. This is Bill Morella from HealthShare Exchange. Thank you for all joining us. And sorry we had to schedule this over the lunch hour, but these days that's when we seem to get the best attendance. So thank you for spending your lunch hour with us. And we'll get started. So for those of you who don't know me, I'm Bill Morella, Director of Data Analytics and Quality at HSX. And Jill, would you like to introduce yourself?
Hi, my name is Jill Ozerkis. I'm counsel to HealthShare.
Okay, great. And just let me just cover a few housekeeping items before we dive into this. So we're going to have about 20 minutes of just a few slides that I'll go through. And during that period, we are going to have everybody muted just to limit the background noise. And then when we start the discussion period, Fatima will open up all the lines. We'll try to keep those open as long as we don't get too much background noise. But please mute yourself when you're not speaking. That should help us cut down on it and leave it open for everyone to weigh in. We are recording the meeting to just make everybody aware. So if you are uncomfortable with that, you can drop off. But we hope that you'll stay with us. So let me start off by talking a little bit about HSX's COVID response. So many of you may be familiar with this. I apologize if it's review for some of you, but I think for anyone who has not been engaged with HSX through this period, and specifically on COVID, it does provide some good context for the population health notice that went out to all the members, I think about 2-3 weeks ago. And that really are the basis for the discussion today. So we thought it would, this is a little bit of a departure for HSX. So we thought it would be helpful to just make these sessions available for people to express any concerns, ask any questions, or hopefully express their support for the approach that we're taking with this. So throughout the COVID outbreak in our area, we've really been focused on 4 central things: keeping people notified of what's going on around them and with their patients, tracking patients, both those who are COVID diagnosed, as well as the overall level of activity in the provider organizations that are in the HSX membership. And then fourthly, providing intelligence. So working with some of our public health agencies to share information with them, so that our region has as coordinated a response as we can, and HSX is contributing as much as we can to the region's response. So I'm just going to review quickly a couple of the things that we've been doing that some of you may be familiar with. So very quickly, after the COVID outbreak started in our area, we augmented our encounter notification service to identify patients who were either COVID positive or COVID suspected as they were admitted into hospitals or nursing homes. And that information allows someone who's using our encounter notifications to keep track of their patients to filter down to just those who are COVID suspected, so they can prioritize them for follow-up or any other outreach they want to do, or just so that they're aware of the patient's COVID status should the patient come in after their encounter that generated the notification. We've also been doing surveillance reports that we've been sharing with the leadership of the health systems and the payers and other community organizations that are associated with HSX. This slide is a little bit out of date in terms of the time frame that it's showing. This only goes through mid-June, but we have started these reports back up again because we, as many of you are, I'm sure, hearing on the evening news, if not somewhere else, cases are starting to pick back up in the region, and we are starting to resume these reports at least once a week, and we'll increase the frequency of those as indicated. But I put this slide up just to demonstrate that the time period when we see surges in HSX's data corresponds pretty well with some of the other information that is coming out from the public health agencies and lab results. And so using the data for this purpose is a good example of what we hope will continue through the COVID registry that we'll talk about in a little bit more detail. Another example of how we can use this kind of data for research-oriented purposes. So early on in the pandemic, the CDC identified the comorbid conditions that put patients at heightened risk should they get COVID, and we see the evidence of that borne out in the data that HSX is collecting, where we developed a very quick risk index for patients with multiple conditions that put them at increased risk. And we found that people that had 3 or more risks had twice the risk of hospitalization as other people, 4 times the risk of mortality, and higher length of stay if they were hospitalized. And all of those findings were significant and have held consistent throughout the pandemic. So we do believe that the data that we're collecting is useful for research purposes, and potentially even we're looking at augmenting the clinical data that we receive with information like this about patients' level of risk. Another quick example. So this is a somewhat busy graph, but the story it tells is pretty straightforward. So this is covering the period from mid-March to about mid-June. So from the period of when we had the peak in our area was around in the middle of this graph, around April 26th or 27th, and thereafter diminished. And what this graph is showing is that in mid-March, we saw a lot of the hospitals start to cancel elective surgeries and to discharge patients who could go to lower acuity settings or be sent home. And we saw the overall volume of care diminish in the first couple of weeks of the pandemic. And the red line on this graph is admissions, and the green line represents discharges. And what we see in the beginning of the pandemic is that for a period of about 5 weeks, admissions were consistently exceeding discharges. And we saw the COVID population in the facilities. This is showing all care, not just COVID patients. But we saw the COVID population swell in all of our acute care hospitals during this time. And then after the peak, within a couple of weeks, you start to see the discharges are exceeding the new admissions, and you can see the overall volume of care starts to pick up beginning around mid-May, and hopefully has gotten better since then. And I show this just to emphasize the validity of using the data in this way. We're used to thinking of HIEs as sort of in this sort of transactional mode of moving patient information around patient by patient, encounter by encounter, so that it's available to someone who's querying for the patient, or to let a PCP know that one of their patients just got admitted for something. But in the aggregate, we're able to use it for these kinds of population health purposes. And I think this is a good sign of the validity of using the data in the form of the registry that we want to talk about. So public health data sharing. So since the very beginning of the pandemic, we very quickly established a memoranda of understanding with the State Department of Health as well as the City of Philadelphia. We're now looking at expanding that to the other surrounding counties. But what we've been doing is helping them with case finding, either through positive lab results that we receive or through clinical diagnoses. For the City of Philadelphia, we're going an extra step and giving them an MPI extract. So basically, our patient database has turned out to be useful to them for contact tracing purposes, simply because for many patients, it represents the most current version of their contact information. Every encounter that we have as a patient gets our contact information updated. So we're able to share that with the public health agencies, and they're using that every day in doing their contact tracing. And I have some good news to share with you. So this is just a couple of weeks old. So the Office of the National Coordinator for Health IT, it's one of the offices under HHS, stood up a grant opportunity focused on HIEs, working with their regional public health agencies. And we were notified a few weeks ago that HSX is one of 5 awardees around the country. So there are about 80 HIEs working in the U.S. So we're viewing this as a good shot in the arm for us. And we proposed a suite of activities that I'll show you in just a second. That each of the HIEs is doing things, some things that are common to all of us, like contact tracing and case finding. But each of us also has some unique things in our proposal that we're hoping to learn from one another. So this is sort of a summary of what we proposed to ONC that has just been awarded. And the first part of this in the upper left, we've been doing case finding and contact tracing assistance for the public health agencies, as I discussed, but we're also increasingly looking at immunization status as being important. We have 16 million vaccination records in our system, and as the COVID vaccines become available, that may become critical to be able to communicate very widely to anyone who may need the information about a particular person's vaccination status at any point in time. Not only to know if the patient has been inoculated, but if it's a vaccine that requires multiple inoculations to be effective, we need to be able to follow up with patients who have had the first but not the subsequent immunizations. So the data sharing that we have been doing is sort of ad hoc, at most daily extractions. And when you're talking about doing contact tracing every day, counts. So we are looking at standing up APIs that will enable real-time communication of this information, either to applications that are being used by the public health authorities themselves, or in the case of immunization status, it may be that we need to work with vendors who are installing apps on people's cell phones so that people can validate that they have been appropriately immunized in order to go back to school or go back to work or to use public transportation. Secondary data use. So here we're talking about standing up a dashboard for the health departments and the offices of emergency management to help them monitor the status of healthcare facilities in real time. So during the height of the pandemic, people were reporting their status in manually to the Knowledge Center 3 times a day. And we're trying to see if we can use the administrative data we're collecting every moment as a way to monitor this in near real time. And the other part of this is going to be about the COVID-19 registry that I'll go into in more detail in a second. New data connections based on public health priorities. So each of the agencies have given us a list of organizations in their jurisdiction that they would like to see sending data to them through HSX, or in some cases sending to other applications that the public health agencies benefit from downstream. So one example of this is electronic initial case reports. This is a new HL7 based standard that allows the EHR to actively screen for patients who may have communicable reportable diseases. And so we're looking at standing that up in partnership with the American Public Health Labs and their AIMS platform that will streamline a lot of the reporting of mandatorily reportable conditions that is done manually today. So it will have benefits for healthcare providers as well as the public health agencies to get better, more consistent, more structured data than what they have been getting from faxed and phoned in lab results throughout the pandemic. And then finally, program management and governance. Part of this is just routine project management and worrying about schedules and resources and budgets. But we're also looking at whether our existing use cases need to be expanded to accommodate this work. And part of the focus of the HIE or the ONC grant is to initially focus on COVID, but also leverage that infrastructure and have it persist beyond the the time frame of the COVID outbreak, and work for other purposes that serve focused public health needs. So at this point, I'll drill down on the COVID registry. So we've had a number of instances where we tried to communicate this to the membership. So we had a webinar back in July, and we've sent out multiple notices about this. And so the COVID registry got started with Robert Wood Johnson, who gave us some seed funding to get us off the ground with this. And the idea is that they wanted to create a national registry of primarily health systems. I think we're the only HIE that was invited to participate in this, to basically stand up a nationally representative COVID-19 registry that would be available to researchers, and it would contain anonymized data on COVID-19 patients. It would include information about the whole patient, not just their COVID-related encounters, so that we could look at things like the comorbidities that might influence someone's outcome, or other patient characteristics that may be unique, that may influence their ability to fight the disease, or even the propensity to contract it. So the problem that we're trying to solve with this registry is that in the early days of the pandemic, there really was no standardized, actionable, and accessible database to understand the trajectory that COVID-19 was going to take in any given area or with any given population. And a lot of the traditional public health data sources were focused primarily on lab results, because it's an objective gold standard for purposes of epidemiology. But the lab results that people were getting in the early days, and this continues to some extent, frequently did not have even very basic information about patient demographics, their age, their race, whether they got admitted to the hospital, what their other health conditions might be that would influence their care. And much of that data does exist in EHRs, but it has not been systematically collected or communicated to the public health agencies in structured ways that they can use. So the registry that we're envisioning will also have benefits to HSX members. So we're looking to stand up this regional registry that will contain data on all the patients who have encounters with providers who agree to participate. It does not require any special effort from the members. All we really need is your consent and agreement to participate. And it's going to be informed by data from across the HSX membership. So, each of the, certainly the academic medical centers in the area and the large health systems have established COVID registries internally for their own patients. But we have the ability, because of the role HSX plays in the region, to augment the data that any given provider might have about the patient with information that other providers have about the same patient. So imagine a patient who, I've been a Penn patient for 25 years. If I wound up in a Jefferson ED, there is other information available from my Penn record that would be useful if Jefferson's doing an analysis and all they have to go on is the information that was available through one ED encounter. So this resource will be accessible to all of you, and our ask of you is that we hopefully will get your support for this activity, and you'll see this as an important contribution that HSX can make to our region's COVID response. This just gives you an example of some of the other organizations that are participating in the registry. And I should mention that we're working with Jefferson in particular to augment the HIE data with clinical data directly from their EHR that is beyond what we typically collect as an HIE. So information about, for example, what drugs a patient was treated with while they were in the hospital, or whether they were on a ventilator, whether they needed ICU care. Most our window into patient encounters has a gap sort of while they are in an inpatient encounter, and we don't get that updated until the end when we get the diagnostic codes, usually several days after discharge. So we don't have great visibility into what happens between admission and discharge. So this is a way for us to augment that data with data out of the EHR, and we're looking for other clinical partners who would like to contribute data in the same way and make the registry richer as a consequence. So this is a complicated diagram, but this illustrates the data model that we are using for the registry. And I'll talk more about specifically what data we're going to incorporate, but this is the format of it. So the idea behind this national registry is that there are about 10 nodes that are participating, and the data is not being centralized. It's not going to be shared with Robert Wood Johnson. It's not going into a common database. Each site will maintain its own data in-house, but a researcher who wanted to get access to the data to answer a particular research question could go to the entire network and with the same query or research question, and they'd be able to get from each of the registry participants an answer that would be easily combinable and easily synthesized, because it was all using a common data model. So this one is called OMOP. I believe it's the outcomes. I'm not going to remember the acronym, but this OMOP is a database that is commonly used in bioinformatics research, and is going to give us the framework for outputting data from the typical HSX HIE database and housing it in a format that is more amenable to research uses. So what patients are we going to include? So we're going to include patients who have encounters or lab results that indicate a COVID-19 diagnosis. So we're not including at this time patients who would test negative for COVID, for example, or patients who might have been admitted as a COVID rule out, or just a suspected exposure without some sort of confirmatory diagnosis. And for patients that we do include, we will have a look back period to January 2017 for other information about those patients. So, looking for things like comorbidities or, someone's encounter history prior to their COVID encounter. We will look back to January 2017 for that sort of information. And of course, all of this will be subject to the normal restrictions on, patients who have opted out of HIE data sharing, super protected data around mental health diagnoses and genetic information, and self-pay encounters if the use case has to do with payers. This is a list of the elements of their data that we expect to include. So as I mentioned, history of prior encounters and procedures, diagnoses, meds to the extent that we have them, lab results, which we are increasingly creating new lab feeds, partly as a result of COVID, radiology reports, allergies, immunizations, vital signs, as well as family and social history and insurance information. So in terms of the data granularity, we're looking at this as being primarily a resource for HSX members, but we do envision that extramural researchers may have use cases for this data and research questions that the data will support. And so this just illustrates how we envision sharing data and what data might be shared depending on who the researcher is. So for researchers who are affiliated with HSX members, we envision that aggregate data obviously would be available, and even anonymized patient level data as well. And depending on what the use was, we may even provide identifying patient level data to an HSX member where that was necessary for their particular use. And an example of that might be if the member had a population health use case and wanted to look at information we had on their COVID patients, and they would want to be able to link other information from HSX with the with their internal information on identified patients. That would be an example where we could see identifying data being useful. For non-members, we would not provide any identifying patient level data. So any extramural researchers who are not HSX members at most would be able to get a limited data set in the HEDIS sense of that term, which is expressly de-identified and would be under a data use agreement. And so they would only be able to get anonymized or even aggregated data that wouldn't even have a raw patient data in it. So the timeline for this, so we did send the member notification out in October. I mentioned that we did have an intro webinar that we did with Robert Wood Johnson and with Jefferson Health System earlier in July. And these two discussion sessions were timed to be a few weeks after the population health notice went out. And we're hoping that we get responses from everyone by December 5th. So that was the extent of the slides that we wanted to show, but we wanted to leave some time for questions and discussion. So Fatima, would you open the lines, please? Fatima, do you hear me? Fatima, can you unmute everybody on the phone? So while we're waiting for Fatima to do that, feel free to type questions into the chat window. So on the control panel, it's down near the bottom. So you can submit questions either in the chat window or there's a question window.
All right. So I'll unmute everyone so that they can comment if they have a comment. Or see if there's any questions. Okay, we have one question, Bill. It says, please clarify opt-out dates, December 5th or December 6th. Initial email had December 6th.
Oh, okay, that might be a typo on my part. So, we will wait for December 6th if that's the case.
Okay. Another question is there anything that we have to do as a community to participate in this?
No, so a great question. So no, there's nothing in particular that you need to do in order to participate. But if you think that the registry, as we've described it, would be useful to you, I'd be happy to set up a meeting with you to just kind of talk through the project that you have in mind and how we think the registry might be able to support it. Or actually, for that matter, if you have grants that you might be applying for instance, I saw one just today that the Pennsylvania Department of Health is releasing, and specifically to look at COVID response in the Pennsylvania area. So, if there are grants that you're considering applying to and being able to flesh out the data from your health system with data from the entire HSX membership, that might be an interesting and novel aspect of your grant proposal that would help maybe make it a little bit more competitive, and we'd be happy to support that.
Okay, that looks like that's it for the questions. We had an individual say thank you for the presentation.
Okay, great. And Fatima, I'm not seeing, I've had the question window open, but I'm not seeing any questions in there. So if there are any others, I'm not able to see them.
Yeah, I would probably have to make you the organizer, but I'll have them on the report from the webinar. after today.
Yeah, I just don't want to miss any if there are others.
Yeah, I don't, wait a minute, here's another one. Will the slides be sent out from this presentation?
Sure, we can do that.
And it looks like that's it for the questions, Bill.
Okay, very terrific. Well, if anyone thinks of additional questions afterwards, please feel free to email me or just give me a call, and I'll be happy to follow up with you. And otherwise, thanks everyone for your attention, and hopefully you'll all decide to participate. And if you have any concerns you'd like to discuss privately, please by all means reach out.
Bill, it was great.
Okay, thank you. Fatima, any last minute questions before we hang up?
Well, one more. Here's one that just came in. Any additional HIPAA required notices to members to share their data?
Yeah, Jill, do you want to take that?
Sure. That's something that we can get back to you on, but we don't provide the HIPAA notices. So I think that's an individual question for each of you. All of the covered entities have, their notice of privacy practices. And if it, doesn't contemplate anything like this, it's possible that it may need to be expanded, but we'll take a peek and provide additional advice.
Okay.
Okay, Fatima, any other questions?
Nope, I don't see any additional questions.
Okay, all right. Well, everybody, thank you for your time and attention today, and hopefully this was informative. And again, feel free to reach out afterwards if something occurs to you after we break. All right, thanks very much.
Thank you very much.
Okay.
Bye-bye.
Awesome. All righty.